So at the outset, let me thank Dr. Sameer Arbat sir for giving me this opportunity to share some very important aspects of pulmonary rehab, which is the most neglected part in treatment with patients with chronic lung diseases. And my warm regards to Dr. Lajwanti, who is my chairperson for the day. So at the outset, let me all tell you that I, being a very passionate therapist towards pulmonary rehab, and Dr. Sameer Arbat sir has given me that platform to serve people in Nagpur as well as in the localized areas around Nagpur, people in Chandrapur not being aware of pulmonary rehab. So thank you so much, Sameer sir. So I'm really grateful and indebted towards this thing that we are at least trying to sensitize people to take pulmonary rehabilitation. So thank you once again. So the topic for today's webinar is pulmonary rehabilitation, newer devices. So why devices? So are we the physiotherapists not, capable of delivering our services? We are, but there are certain limitations to reach out to patients. That is why we need to provide them with certain devices which can help them to maintain their therapy. That is why this webinar is formed to let us know, understand that devices play an important role in maintenance therapy of pulmonary rehab patients. So we all know that chest physiotherapy with bronchial drainage is the standard treatment that we use to mobilize the secretions and remove the secretions from the respiratory tract. And thereby we are treating so many lung conditions such as cystic fibrosis, bronchiectasis, bronchitis, bronchial asthma, to name a few. We all know that the CPT, that is the conventional chest physiotherapy, has been shown to be effective in maintaining the pulmonary function and to prevent the respiratory complications in these patients. However, standard chest physiotherapy is very, very intensive, time-consuming and laborious. We all know as physios, if we have 4 patients in the ICU, then am I audible?
Yes, ma'am. Sorry, some technical issue. Just you're not audible for a few seconds. You can continue.
All right. So please let me know in the chat box so that I can just stop myself. So for this reason, wherein the patients, they are not able to reach us, and this chest physiotherapy being very, very laborious, and once the patient is discharged from the hospital, we lost their follow-up. So for this reason, it is necessary that we need to give them something so that they maintain their respiratory exercises. So in recent years, there are a lot of devices of respiratory physiotherapy that have emerged in the market, and they will offer alternative to standard chest physiotherapy. And these devices the patients can carry, they are less time consuming, and they offer greater independence to the patient. Like they can perform the respiratory exercises at their own ease. So for this reason, the devices are aimed, basically, they are designed to facilitate and improve the mobilization of secretions, because this is the major area where we as chest physiotherapists, we intervene. Because if the lungs are clear of secretions, then the patients maintain its oxygenation, and then no breathing discomfort is there, dyspnea improves, and patient's quality of life improves. So the first and foremost thing that a chest physiotherapist is called up is for mobilization of secretions from the airways, and thereby we are planning to, or we aim to, improve lung ventilation and to improve the overall pulmonary function. So these devices, they are basically to increase the patient's compliance. Patients should stick to the breathing exercise. Patients should stick to the airway clearance technique. And this gives a feeling of independence to the patient. He has full control over the therapy, and definitely these instruments are designed because they are easy to use. They are not very complicated instruments. So overall, if we look what all instruments are there that we can prescribe to our lung patients with chronic lung diseases, humidify, we know that patient comes, walks into the OPD, and we want to humidify his airway. So we have nebulizers present. Then the foremost important thing is there are variety of instruments available in the market to remove the secretions. And all of them, they are working on the principle of oscillatory positive expiratory pressure therapy. Then the next category comes to increase the lung volumes. There are instruments which help to increase the patient's lung volumes apart from the thoracic expansion exercises. Then there are instruments to increase the respiratory muscle strength and endurance. Because physiotherapists, we deal with movements, mobility, skeletal muscles. So let me tell you, even the respiratory muscles, they require strengthening. So we have instruments to strengthen the inspiratory as well as the expiratory respiratory muscles. And finally, we need to monitor the patient's ongoing therapy. So peak flow meters are available, pulse oximeters in rehab. We just need to monitor the saturations. So briefly, we can categorize the instruments based on these categories. So what are the most commonly used instruments? We all know that PEP therapy is very, very common, and we use the oscillations to mobilize and loosen up the secretions from the airways. And the most common ones are flutter, aerobica, then incentive spirometer. All the patients in wards and ICUs is prescribed an incentive spirometer. But then we will discuss today which type of incentive spirometer is more beneficial for the patient. And then inspiratory muscle training devices. Some institutes, they are using it, some are not aware of it. But less known are these ones, the breathers, the threshold IMTs, the power breath devices. We have double action in which we have inspiratory muscle trainers plus the positive expiratory pressure oscillating device in the same institute. So patient can use it for removal of secretions, and simultaneously the other end can be utilized for strengthening the muscle. Then high frequency chest wall oscillations could be present at hospital setups, but individualized, it's costlier. Patients with cystic fibrosis and bronchiectasis, they may be prescribed with this kind. And intrapulmonary percussive ventilation, very few, they know it, they use it. So we will just see in brief about what is the principle of the working, how many times we need to tell the patient to exercise, and what are the prescription principles. So coming to the positive expiratory pressure, that is PEP therapy. So basically the simplest form of PEP therapy, it consists of a chamber with a blue piston, which is connected to a mouthpiece and a resistor setting. So basically we are giving various resistors to the patient's expiratory flow. Patient blows into the machine, and then we are offering resistance. So this resistance, it causes some kind of back pressure into the patient's airways and thus helps to mobilize the secretions. So this device, the PEP therapy devices, are basically for removal of secretions. They are available with a mouthpiece. If the patient is not comfortable, then they can be used with a mask as well. And the aim is to blow so that this blue piston, it comes between the two arrows that you can see here. So that is what the patient is expected to do. So we have various resistors, color-coded resistors, and then they are connected to a manometer to monitor the pressure, because we cannot expect the patient to forcefully and violently blow out. We don't want that. So the PEP therapy masks, they have an inspiratory inlet and expiratory inlet, a one-way valve, and a resistor fitting which is connected to a pressure manometer. So PEP devices, they were developed in 1970s in the United States, and they were considered as an alternative to conventional physiotherapy. So they consist of a mask, a one-way valve, and a manometer, which we are expected to tell the patient to blow into the device to maintain a pressure of 10 to 20 centimeters of water during expiration. And you can change the resistor settings starting from the mild colors to increasing the resistance as the patient progresses. So basically, they were initially designed for children with cystic fibrosis. And this device is considered to allow the air to go back behind the secretions. So as to mobilize the secretions towards the central airways, and thereby it helps in preventing the or helps to prevent the collapsing of the alveoli. So this is very, very important instrument, utilizing the oscillations, even useful for children. They don't have to, master the technique. Like ACBT and autogenic drainage, we want the subject to master it. So just a simple device. Now coming to the handheld portable devices, which work on the oscillatory positive expiratory pressures to remove the secretions. The first and the foremost, very important and very commonly used, very well known by the physiotherapist, is flutter. So flutter is a device that was developed in Switzerland, and it combines positive expiratory pressure with high frequency oscillations within the airways. And the main aim of the flutter is to clear the mucus which is present in lung disorder patients. So now flutter, as you can see, so this is just a sample that I have got. This is the variant of flutter. This is called as a shaker. Same thing, same principle. It works on the same principle of expirating into the device so that you create a, if you can hear, we have a metal ball inside that. We have a metal ball inside that which oscillates when you blow into the device. So when you blow, you create a positive pressure, take a deep breath, blow into the device. So when you blow it, there is the steel ball inside the device, it oscillates. And that is how those oscillations are conducted into the airways. So flutter, it causes the steel ball bearing, which I just showed you, to oscillate at higher frequencies. But the only thing with flutter is it is gravity dependent. You cannot put it down like this, neither you can tilt it like this. You have to optimally hold it in the horizontal position while the mouthpiece is snugly fitted around the lips. Okay, so this vibrations going into the larger airways, causing intermittent expiratory pressures, helping in loosening of the mucus. So most of the positive expiratory pressure devices work on the same principle. Flutter has got a steel ball which oscillates when you blow into the device. So you have to take a deep breath in, hold it for 2 to 3 seconds and blow into the device, but no violent blowing. It has to be very, very slow, steady and prolonged blowing so that the vibrations are easily transmitted into the airways. So this is what it happens when you blow into the device and the steel ball oscillates. So what is the application for this? The hold of the breath for 2 to 3 seconds is important after a inhale or a deep volume or a deep lung inhalation. So the expected thing, they say that in a given sitting, you can give around 15 repetitions for 3 sets. But when patients come to us, we cannot expect them to complete 3 sets, 15 repetitions in one sitting. So you can train the patient. You can tell them that to begin with, you can give 5 blows and do diaphragmatic breathing exercises and then do another set. So start with 5 repetitions for 3 sets, and then your aim is 15 repetitions for 3 cycles when he comes to a pulmonary rehab setup. But at home, you have to begin with lower number of repetitions. So the only thing is, because flutter is gravity dependent, the patient has to monitor, adjust the inclination, moving the flutter up and down so that he gets the optimal vibrations into the chest. So that is very, very important. So it is very easy to teach the students also, the children also, those who are suffering from any kind of lung disease. So it is very portable, handheld, easy to use device. The next one is Acapella. Again, it works on the same principle. It is available in the market in 3 different flows because it offers resistance to the expiratory flow rate. So we have low flow, high flow, and Acapella choice. So anything we have, I'll just share the slide with you. The low flow acapella, they have these models, they allow for less than 15 liters per minute of flow through the device. High flow are allowing a flow rate of more than 15 liters. And the acapella choice is the optimal one that we use for most of the chronic lung disease patients. It can be used with a mouthpiece, or it can be used with a facial mask also. Again, what is the principle of acapella? There is a valve which interrupts the expiratory flow, thereby generating oscillating positive expiratory pressure, same as that of flutter. But it works on an outweighted or counterweighted plug and a magnet kind of a system inside it, which helps to give you an interrupting expiratory flow rate. But this is not gravity dependent like the flutter. So it is independent. It doesn't, the change in the position of the acapella will not affect the effectiveness of the device, right? So these are the 3 models. Most commonly one is the acapella choice for chronic lung disease patients. For geriatric individuals, you can go for low flow systems, less than 15 liters per minute. And for ideal patients, those who are healthy, but because of certain post-operative care or because of abdominal weakness or abdominal surgeries, such patients with no lung disease, but you need to clear up the mucus, so you can go for high flow acapella device. So this is what the acapella device is. At one end of the device, you have a resistor setting. Like I said, with the manometer, you can either fix the resistor and achieve the pressure of 10 to 20 centimeters of water. Flutter does not give you any kind of resistor settings, whereas acapella has a resistor setting of 1 to 5 at the another end of the device. The Common thing with a cappella is you can fit it with a nebulizer. So patient is simultaneously doing a mucus clearance technique and plus his lungs are getting nebulized. That is the beauty of a cappella. Coming to Quake. Quake was again a handheld device that was available in the maybe last decade or so, but Flutter and Aerobica, they have taken up the market now. So it has got a handle, a mouthpiece, and there is a barrel which the patient has to move manually and blow into the device. So that's the only thing that it is there. While the patient is blowing in the device, the patient has to move the barrel manually. It is portable, easy to use handheld device, and two barrels are present which fit into one another. So, and that is how when the patient blows into this, the oscillations are created. The faster the patient is moving, the less is the pressure. So if you want more pressure, tell the patient to move it slowly. If when the barrel is moving slowly and simultaneously the patient is blowing, then there is more pressure offered. If he's moving the barrel fast, then less pressure is, so to begin with, tell the subjects to move it faster. Coming to the next one is cornet. Again, was used centuries back, but it is still a device available. It is a semicircular tube kind of a thing with a latex hose inside it, which buckles and unbuckles when you are, blowing into this kind of a semicircular tube. So this buckling and unbuckling of that latex hose, it causes oscillations. It's like blowing into a kind of an musical instrument or something like that. It was developed in Germany, and because of this movement of the latex-free hose, the oscillations are created. Again, based on the principle of oscillating positive pressure. And what is the aim? To mucus, remove the or to clear the mucus from the airways. So the mouthpiece can be adjusted to produce the optimal effect, and cornet is gravity dependent. You can use it in anyhow patient is comfortable. And another thing is, like the flutter only, cornet cannot be used with nebulizer. So the only device that we have seen till now that can be used with a nebulizer is a cappella. Coming to aerobica, again, aerobica utilizes the oscillating positive expiratory pressures to loosen the secretions from the lung. Preferably, it should be performed in sitting position. Again, this is not gravity dependent. It has got a mouthpiece, a case, a valve cartridge, and a resistor indicator. As you can see here, you can set the resistor beginning from 1, 2, 3, 4, and 5, whatever the patient is comfortable. So when the patient blows into the aerobica device, the patient is expected to make 10 blows to begin with, and we have to achieve it 10 to 20 times. And when the patient blows, the patient is encouraged to stop the blowing. For example, he blew for 10 times and then he feels like coughing. So encourage your subject after the first cycle to do a huff maneuver and try to remove the secretions into the sputum mug. So this can be done after every cycle. So the patient understands now the secretion has come up to the throat and I want to throw out, right? So you should encourage coughing or huffing between cycles also, because unless and until the proximal airways are clear, the peripheral secretions will not pull up here. So encourage huffing and coughing between cycles of positive expiratory flow devices. So moreover, we have to understand that when you begin with, don't be very over enthusiastic, because you only understand if you blow out for 10 times, you get giddiness. Being normal individuals, they are already hypoxemic patients with respiratory muscle weaknesses and they are catching sick. So you have to understand that you have to understand and prescribe the repetitions which is suitable for the patient's need. And I request that whenever you are using the devices, just use a pulse oximeter and see the patient is not desaturating. That is very, very important. So aerobica can be combined with a nebulizer, that is the Aero Eclipse nebulizer, and it is an effective way of incorporating isotonic or hypertonic saline along with the PEP therapy. So as the patient is blowing, nebulization is also going on. Moreover, in order to understand that the patient is not overtly or forcefully or violently breathing, so that it has got a disadvantage that the patient's airways are getting collapsed, you are aiming to clear the secretions by creating certain oscillations into the lungs, but in the bargain, the smaller airways are getting collapsed because the patient is forcefully expiring. So this should not, we can have a visual feedback attachment into the manometer wherein the patient is instructed to maintain the pressure so that the airways, they don't get collapsed. So this was all about devices which help to clear the lung secretions. So we can just name them again: flutter, a cappella.
Ma'am, sorry.
Yes.
Yeah, I think so. Dr. Lajwanti has put in the chat that she is not able to see the PPT. Though I can see your PPT. Anyone else who has trouble with the PPT?
Is my PPT available? Please put your comments in the chat box.
Okay. Yes, everyone has given a thumbs up. Yeah.
So
You can
maybe some
continue.
network issues. Yeah, maybe some network issues. So moving ahead to devices to increase the lung volume. We have seen the devices which clear up the mucus. Those are flutter, a cappella, cornet, and aerobica. Most commonly one used are flutter and aerobica, easily available in the market, can be prescribed under the guidance or supervision of your pulmonologist, and explanations can be given during your pulmonary rehab sessions. Now, devices to increase the lung volume, what we actually do is we teach them thoracic expansion exercises. Okay, take a deep breath, hold it for 5 to 6 seconds, give them certain vibrations during exhalation, and try how many times can you give and how many patients in a day. So the incentive spirometer being a savior, everyone prescribes incentive spirometer to all the patients, whether it is respiratory patients or whether it is surgery patients, whether it is geriatrics, long-term bedridden patients, spirometer is always there. So spirometer is basically a device wherein you want to improve the patient's inspiratory effort, right? So it is designed to encourage the patient to take deeper breaths. That's the whole purpose. And what is happening? We are trying to increase or maintain the inhaled lung volumes. You want to improve the sputum expectoration, because when you take deeper breaths, the air goes behind the secretions, and when you exhale out, then the secretions start moving. So deep breaths are very, very important in mucus clearance. And because we are clearing the mucus, we are giving them deeper breaths. So the chances we are helping the patient to get rid of any lung infections or don't catch any infections after the surgery. So now we all know that this 3-ball spirometer is rampantly used in the market, and hardly anyone uses the other one. So the 3-ball spirometer is a flow indicated spirometer. It has got fixed flow wherein we have 600 cc, 900 cc and 1200 cc. Patient is instructed to keep the spirometer at the eye level, keep the mouthpiece inside, and through the mouthpiece, the subject is told to breathe in. That is the way we actually teach. Suppose the patient has this, so you cannot say कि नहीं आप दूसरा लेके आओ, right? So what are we supposed to tell them is the correct pattern of using incentive spirometer. First and foremost, patient has to take a slow breath and try to maintain the ball at least for 1 to 2 seconds on the topmost position. That is the one thing that we need to teach them, those who are using the flow indicated spirometer. And then gently blow out through the mouthpiece only. The only thing that you want to teach your subject is the correct pattern of breathing. What is the wrong pattern of breathing? Using all my accessory muscles and using all the upper chest movements. Look at this. If the patient is doing this, what are you teaching your subject? To use all the accessory muscles possible, and we have a separate session wherein we are teaching them to slow down with the use of accessory muscles, don't get dyspneic, don't increase your energy cost expenditure, and here the patient is doing. So this should be avoided. The pattern of breathing says slow, steady breath using the lower costals, keeping all the neck muscles, chest muscles relaxed. That is the correct pattern. And my great students have taught me another technique. They put the spirometer upside down and they use it as an expiratory device. They blow into it. Really? Do we really need to teach this? No. Incentive spirometer is an inspiratory device which is aiming to increase the patient's lung volume. So kindly do not use it upside down and give them blowing. It's not required and it's not helping the patient. So you have better devices for expiration to clear up the mucus, because you don't have to increase the expiratory airflow. And if you teach blowing into the incentive spirometry, turning it upside down to a COPD patient, you are actually causing more collapse of the smaller airways. So please don't do that. So the best one that you can give them a patient if he's affording is volume indicated spirometer. It has got the volumes fixed starting from 250 to 2500. What is the indicator? You want your patient to breathe at 750 ml. What you do, tell the subject to blow into the device, take a deep breath through the mouthpiece, and there are smileys that are seen onto the right side of the device. An unhappy smiley, a happy smiley, and again an unhappy smiley. So if he's underdoing it, the cursor just comes to the first smiley. But if he's optimally doing it in a correct way, then the cursor shows that the cursor comes to the happy smile. So that is what you're supposed to tell your subject. Slow, deep breaths, bringing the piston or the marker to this happy smiley and trying to achieve the volume. And slowly and gradually you can. So I request physios, if your patients are affording, try to go for a single ball incentive spirometer, which is a volume indicated spirometer, right? So whenever we give them the repetitions, we say 10 repetitions. Every hourly the subject is expected to do, but when the patient needs to cough out, because I told you lung volume expansion exercises you're giving, so patient may be tempted to cough out and you remove the secretions, encourage them to do huff and cough in between and let them clear their secretions in between. So the correct pattern is using lower costals. That's very, very important for incentive spirometer. When we talk about spirometer, we ask a spirometry reading. What is the spirometric reading? So spirometric reading means the patient has some PFT reading, which measures the patient's expiratory or exhaled air, and it is for data maintenance. Wherever what we call it as pulmonary function test. Now portable devices are available. What we are talking of incentive spirometer is to improve the lung performance and to measure the inhaled air, those with major illnesses, major surgery. So that is the basic difference. Spirometry, it is incentive spirometer, which is a device, and spirometry is pulmonary function testing. That's altogether different. All right. So as I gave you the demo, so that is how, but important thing is you have to hold it for 2 to 3 seconds at full inspiration and expiration through the device itself, but you should be slow, calm and steady, no forceful expiration. That's all you all need to remember. Right. So what are the uses of incentive spirometer? Prevention of pulmonary complications, mobilization of secretions and opening up the lung areas, improve the ABT. Certain studies have demonstrated that HQR, that is health related quality of questionnaires, have shown improvement after incentive spirometer usage. So you all can take up that work if interested. Now, this is the very, very neglected domain of pulmonary rehab. And as physios, we need to understand that it is the dire need to strengthen the diaphragm and the external intercostals, which are the primary inspiratory muscles, which none of us do, because either the machinery is costly or we don't even, because rampantly we do CT, MRI, blood reports, everything possible for a pulmonary patient, but none of us even want to know what is the respiratory muscle strength. So this is a very, very, so respiratory muscle strength, according to the American Thoracic Society and European Respiratory Society, they say that respiratory muscle strengthening should be an inseparable part of pulmonary rehabilitation. If you want better results, no complications, you want to lessen down the length of stay in the hospital with less exacerbations, so you should increase respiratory muscle training. So if it is respiratory, it includes inspiratory training and expiratory training. It is not like that just picking up a 5 kg dumbbell and start working out. No, you have to have a baseline. So what is the baseline? You have to do a test called as a PI max and PE max test. So you determine the patient's maximum inspiratory pressure and maximum expiratory pressure. So when you want to determine the patient's maximum inspiratory pressure, so you have to first completely empty your lungs and then hold the mouthpiece and then inhale deeply. That is what it is. So this is a handheld respiratory pressure meter which will record your PI max. If you blow into the machine, it will record your PE max and that will give you a baseline. So whatever the baseline that comes, for example, it comes inspiratory, PI max comes as 100 mm of Hg. So you have to begin training at 30%. If patients are very, very chronic, patient has just come out of the ventilator after months together, or he was had a lot of exacerbations, so you can set a lower value as low as 15-30%. Say you can go to 15% of whatever this PI max, PE max values are, and then you set up your aim. And then gradually you need to increase the resistance so that the patient inhales against the resistance or patient exhales against the resistance. So this PI max and PE max recording is very, very important. So inspiratory muscle training devices, they are very important treatment modalities in COPD patients to improve the strength and endurance of the respiratory muscles, to reduce the dyspnea levels, and to improve the patient's functional capacity. You all know that how do we measure the functional capacity? By doing a simple test called 6-minute walk test. And health related quality of life questionnaires, there are generic questionnaires present in the market, but we do not use them like SF12 or SF36. We use disease specific health related quality of life questionnaires like SGRQC, chronic respiratory disease questionnaires. These are present which are more specific to the patient's need and symptoms that he is suffering from, right? So coming to the first IMT device, which is a breather, it is a handheld respiratory muscle trainer, which uses both inspiratory and expiratory muscles. So the breather aims to train the diaphragm by how to improve the breath support for speech production. It improves the swallowing in patients with dysphagias. It causes a good cough. It helps to reduce the dyspnea. So now cough is an expiratory maneuver. So because breather can be given for expiratory muscle training. That is how. Swallowing is effective in patients with dysphagia. So if you give respiratory muscle training, so swallowing parameters have improved in patients. So that is how patients with buccal paralysis, so patients have shown improvements with respiratory muscle training. So that is how. So breather is available with 11 independent settings, both to train the inhalation as well as for exhalation. And sometimes it can be used with breathing or speaking valves also. So that is also the beauty of this instrument. So breather, it looks like this. It improves the strength and endurance of the respiratory muscle, works on the shortness of breath of the patients. The hyolaryngeal complex gets activated if you strengthen the muscles of respiration. Even the buccal muscles shows improvement, and thereby the swallowing functions improve, the speech production improves. So cough productivity improves because expiratory muscle training, you are training the abdominal. So the cough definitely will show improvement, and it can be given to all pre or post-operative patients. So these are the benefits of breather. Coming to the next genre of inspiratory muscle trainer, that is the threshold inspiratory trainers. So these are actually lightweight devices which are coming in plastic cylinders with an airflow valve at one end. This is the airflow valve, and it has got there is a spring inside it. Okay, you can appreciate that there is a spring inside, adjustable spring through which you can adjust the pressure. I have not yet attached the mouthpiece to this. So can you see, if I roll this, the spring gets tightened. And there are values ranging from 9 centimeters of water to 41 centimeters of water. So the more tightening I do with this threshold, the more resistance it will offer to the inspiratory muscle. It is an IMT device. So if I loosen up, the spring gets unloaded, and then I can fix up a setting, say around, if I set it at 13 centimeters of water, so the spring is actually loosened. Then I fix the mouthpiece, and then I do inhalation and exhalation through the mouthpiece only. This is an inspiratory training device. So this threshold IMT is designed to strengthen the respiratory muscles, especially the inspiration. So first you blow out, put the mouthpiece inside and keep on blowing in and out through it, say for 10 repetitions. Okay. And you need not forcefully do it. You need not forcefully do it because the resistance is set. Because we have tested the respiratory muscle strength, we know the baseline, and we are starting with 20% of the PI max. So this is very, very minimal for the patient. Patient just needs to blow in and blow out through the device. 10 repetitions, 3 cycles, increase to 15 repetitions, 3 cycles. Then we have to give 15 repetitions at a time into 3 sets, 5 times in a week. So that is how the respiratory muscle strength keeps on increasing, and the Resistance can be increased by turning into the knob, turning and tightening the spring because it is threshold loaded, and then blow into the device. It has got a one-way valve. That means it offers resistance only during inspiration. Expiration is free. It doesn't offer any resistance to your expiratory flow rate. So simply using this device, helping the patients to strengthen the inspiratory muscle is the need of the hour. So this IMT, they are actually giving you resistance to the inspiratory muscles by exerting sufficient negative pressure to the airflow. So the patient has to take, the moment you set the resistor level, the patient has to take a deep breath well enough so as to overcome the spring pressure. That is why the name threshold IMT. That's all. So a handheld device, as you rotate it, as I told you, it moves up and down the scale, showing the current pressure values, very well depicted. So initially, if you don't want to give them the repetitions, tell them that they need to do it for 5 minutes. But very tiring for the patient. So the best way, if to have a PI max value, set the pressures to start with at least 30% and then gradually incremental increase by 2 to 4 centimeters of water over a period of, so today I'm doing at 9. Then over a period of 6 weeks, I gradually increase it to 13 to 15. So whatever the markings that are available here, you can set the resistance accordingly. So the red dial needs to be turned to set the resistance level. Then you have to breathe in through the mouthpiece, cover the mouthpiece. The lips should be tightly sealed so that there is no air leak. Tell the subject to breathe in and out without removing the device. The patient should not inhale and then exhale. While exhalation, he is not supposed to remove the device. You can start with 5 to 15 minutes in a day, or you can break up into 5 minutes throughout the day for 15 minutes, but you need to achieve that target and then gradually aim that the patient is exercising at least for 20 to 30 minutes in a day. Even he can do it in incremental manner, doesn't matter. 20 minutes continuously, he can breathe in, breathe out. He can't do that, right? So you can have incremental settings throughout the day, interspersed throughout the day. And the therapy should be 5 days in a week, the way we do it for skeletal muscles. Right? So there are inspiratory muscle training protocol using pressure threshold device. They have been shown to be effective to reduce the dyspnea in patients with COPD. And they said that PI max baseline needs to be considered and set up a load of at least more than 30% of the patient's baseline PI max to get optimal results. Now coming to the next is the power breath pressure threshold breathing device. Again, it works on the same principle as that a calibrated spring-loaded valve. I have another version. This is a power breath, the advanced version. So if you see this device, we need to again inhale. It is an inspiratory training device. If you open it, there is a spring loaded inside it. And you on rotating it, it will show you the pressures. So for beginners, this is very, very good because the pressure is the readings are as low as 1, 2, 3. And for every marking, you are giving a pressure of say 2 centimeters of water. So this is say the maximum reading is 9. So you can go up to 20 centimeters of water and then switch to the breath one. The moment you tighten up the spring, it gets loaded. You can just fix up, then attach a mouthpiece and start breathing in. So these are the mouthpieces that are available. For example, if you cannot give this to a patient, you have your OPD set up. You cannot give a single device to a single patient. So you can tell them to buy this 200 rupees mouthpiece, which is a disposable one. They can sanitize by themselves. And for each patient, you can just utilize it. Patient does inspiratory training in your setup, and he takes his mouthpiece at home, cleans it properly, and comes for the next session. This needs to be sanitized well. It is washable, easily washable. So this can be done by the physiotherapist. So again, power breath works on the same principle. It has got scientifically proven results. Researchers are available they have used power breath devices in clinical trials, and it causes drug-free breathing device. They call it as a drug-free breathing devices. Moreover, the power breath is now showing its use in the sports community, and people are now using it in athletes, in people, those who are involved in cycling, running, swimmers. they have started using respiratory trainers now for their training sessions. So it has, again, the same principle. Power Breath has got a calibrated spring-loaded device, and the pressures are set in centimeters of water. So the only best, more scientific thing about Power Breath is it has got an accurate measurement of the training load. You can actually know that, okay, this much pressure that you are set for the patient, and the patient will be breathing against this. So the spring-loaded valve only opens when you achieve that optimal pressure through your inspiratory effort. Right? So the conditions, now this is the list of conditions. I feel nothing is left, wherein including patients with respiratory ailments, congestive heart failures, neurological patients such as Parkinsonism, muscular dystrophies, amyotrophic lateral sclerosis, even patients with ankylosing spondylitis, myasthenia gravis, everyone should be encouraged to train their respiratory muscles. Very, very helpful. It will help to increase their quality of life by causing less exacerbations, less debility, and having a better breathing pattern, right? Because everyone then ends up with bedridden this thing, and their quality of life is drastically affected. So patients with, even with spinal cord injuries, then sleep apnea patients, patients with obstructive sleep apnea, they are also very well benefited by using respiratory muscle trainer. So now it is we, the physios, that we, the way we like the way we tape patients rampantly. Oh, you have a, okay, I'll fix it. The way you manipulate patients, okay, you have a neck problem, let me give you Mulligan. That way you should say, no, you are a patient who is at risk of developing pulmonary complications. So let me tell you something about respiratory muscle training. This is the need of the hour. So this is a huge list where we can use respiratory muscle training in such patients. And these are certain supporting evidence that the dyspnea drastically reduces the respiratory, the inspiratory pressures improve, the peak expiratory pressures improve, the strength of the muscles improve. So there is a lot of evidence, lot of research which is available with the use of inspiratory muscle trainings in COPD patients as well as in other patients. Now coming to expiratory muscle trainer, how does this help? You know, expiration, if you cough, if have you ever treated a patient who has undergone an abdominal surgery and the patient is trying to cough? What is the first thing that we do? We just need to support and prevent the incision, and he has got a very, very weak cough, and we get a call saying that the patient is at risk of developing post-op complications, so you need to train the patient for chest PT, right? Expiratory muscle trainer is basically for your expiratory muscles. So because if you train your expiratory muscles, patient will have a strong cough. You know, suppose you give a PEP device to a patient, but he is not able to blow out, he doesn't have that much of strength only, then what is the use? How will the mucus will mobilize? So this is the way inspiratory trainers are used. The same way we need to incorporate expiratory trainers as well. So breather has got both inspiratory and expiratory functions, right? So expiratory trainers, they are the devices, easy to use, and it exercises the expiratory muscles and thereby increasing the strength and endurance. Handheld devices, easy to use. Only difference is what? The patient has to blow into the device after a maximum inhalation, right? So who is expiratory training for? For whom? So it is only for those patients who are unable to empty their lungs completely, and special category of patients, particularly with dysphasias, with dysarthrias, with elderly patients, those who have started becoming debilitated because of advancing age, right? Expiratory muscles are very often seen that they are not able to cough well and they are not very well recruited. So with this device, we plan to recruit the expiratory muscles even in critically ventilated patients. So that is how these devices are now coming into market. So weakness of the abdominal expiratory muscle will lead to poor cough, ineffective clearance of secretions, and therefore increasing the risk of re-intubation. So actually we are aiming that. We are not just trying to increase the expiratory muscle strength. No, these are the advantages of training them for expiratory muscles also. Right? Now coming to combo device, I just found one combo device which is present, which uses inspiratory as well as expiratory both. So inspiratory is for strengthening the muscles and PEP for clearing the secretions. So these devices are the dual action IMT PEP devices. which increases
Ma'am,
the lung. Yes.
ma'am, we just sorry, we are
Yeah.
just left with 11 minutes of the meeting.
Yeah. So yeah, we'll be finishing. So I think just few slides left.
Yes, ma'am.
Yeah. So dual action is you are actually training for inspiratory muscles as well as you have expiratory in the form of PEP. That means you are helping to clear the secretion. So it has got two ends and both the ends can be used as I have shown earlier. So it has got three modes. So if available, you can have a look. This is Aerofit. Now it is used by sports person and it is the world's truly smart breathing training device with 17 unique breathing sessions. And there are personalized programs with real-time guidance to the, so this is now in thing with the sports individuals. So this measures the current lung function and it has got a Bluetooth connectivity also. So simultaneously, the patient first gets his baseline values and then the resistance is set and then the patient does the respiratory strengthening with this device and then he can progress it by adjusting the inflow outflow. So it is for inspiratory as well as for expiratory. So both the sides there are resistor settings available, right? So it is can be connected to a specially designed app and the data will be interpreted according to the age, gender, height and weight of the subject to give them tailored training sessions. That is the beauty of this app, right? Now coming to high frequency chest wall oscillations. Again, it is for airway clearance in patients who are unable to cough out, and positive pressure air pulses, they are used, which are applied to the chest in the form of an inflatable vest. So the vest is worn by the subject. I'll show you the picture. So the pressures that we use are around 50 centimeters of water and the air pulses, they oscillate the chest. That is why it is called as high frequency. At 525 hertz, it oscillates the chest. The way we do vibrations manually, so shear forces are created, helps to loosen the secretion. So babies with cystic fibrosis, babies with bronchiectasis, with congenital disorders, this is the high frequency chest wall compressions are very useful. Coming to intrapulmonary percussive ventilation. So sometimes the pulmonary infections are very life-threatening in small kids. So intrapulmonary percussive ventilation, it is a pneumatic device that delivers air as well as aerosol into the lungs at a frequency of 200 to 300 cycles per minute. And reports are said that it is a very useful device to clear the secretions. So it combines aerosol inhalation as that of nebulization and internal percussions which are applied via a mouthpiece, right? So the patient initiates the flow of the gas and during inspiration, the pulsations are delivered to the patient's lungs, like we vibrate, right? During an internal percussion. And interruption of the respiratory flow, it allows for passive. The moment the patient stops breathing, there is a passive expiration. So intrapulmonary percussive ventilation as part of preventive pulmonary regimen, it reduces the days of antibiotic use and hospitalization for respiratory illnesses, both in patients, elderly, young patients, patients with neuromuscular diseases. Very useful device, but it is used only in corporate hospitals, right? So this is what IPV is all about. So, well, I'm done with my talk. So Samir sir has told me to just introduce you all with my setup at Sadar. So we are working with Akhtar's Physiotherapy Rehab and Research Center at Nagpur, and we are dealing with all kind of cardiac specialty wise. And of course, we have pain management, yoga and meditation being my specialty. And obesity is my interest. So we are catering to all these needs. This is my setup at Sadar. This is the waiting area. We have a separate room for electrotherapy and exercise therapy room, wherein we give all kind of floor exercises with electrotherapy modalities. This is the cardiorespiratory fitness room with a higher end treadmill connected to the telemetry, where we monitor the patient's ECG and real-time blood pressures while the patients are on treadmill for angioplasties and CABGs, and a cyclogometer, and a very spacious place. And this is something for great training, a smaller passage that I have utilized. So this is all about Akhtar's Physiotherapy Rehab Center located at Sadar. And Samir sir, once again, thank you so much for giving me this opportunity. Thank you once again.
Yeah, so thank you very much, ma'am. This, I suppose, is the most elaborate presentation that I've seen on newer respiratory devices,
Thank you
and
so
some
much.
of them were pretty new for me also. I've seen that there's been a lot of devices which are being used nowadays by the sports person
Persons.
for respiratory, increasing their respiratory health.
Yeah.
So one question I had, few points that I realized are very important, which we often see during the round, is that the patient is using the incentive spirometry, and the patient is using his chest muscles, shoulders, and the whole body completely. So,
Correct.
uh, for referring a patient for pulmonary rehab, what are the requirements? Do you require a spirometry? Do you require a 6-minute walk test? Or do you require any indication which says that kindly enroll the patient for COPD bronchiectasis?
Yeah, only the requirement at your end would be to give us a green flag that the patient does not have any PAH. The
Okay.
patient's admission records if the patient has been admitted or has landed up into respiratory failure, and whether the patient is fit as far as desaturation episodes are concerned. Spirometer, the patient can buy, or I provide them at my setup. They just need to buy a mouthpiece, detachable mouthpiece of 200 rupees, and inspiratory muscle trainers are available with me. And the 6-minute walk test, as it is concerned, we do here, or 6-minute walk test distance will just tell us about the patient's functional capacity and how long we can go. So that is, but red flag areas need to be very clearly mentioned. So if the patient has had a syncopal attack into the OPD or something like that, patient is having hypotensive syndromes and all, this needs to be just highlighted before we start with the pulmonary rehab.
Also, a lot of patients of COPD come with muscle wasting. These are the patients who require upper uh,
Yeah,
body strengthening, lower body strengthening. So,
absolutely.
what all is
Absolutely.
a part of their rehabilitation other than these devices?
These devices are for skeletal muscles, which we use for breathing, but for strengthening of upper limb and lower limb. So, in fact, it has been said that in COPD patients, if you give upper limb strengthening, they get dyspneic very fast. So, you have to start with very low resistance exercises or very minimal therabands for strengthening their upper limb muscles. But for lower limb muscles, we can start with walking programs if they are obese. If they are like the pink puffer types, the blue bloaters type, then we can give them a non-weight bearing aerobic training that way. So we have to utilize, because strengthening is an inseparable part of pulmonary rehab, whether it is respiratory muscle strengthening or skeletal muscle limb strengthening. That is a part of rehab. So wasting, yes, they need strengthening, and there are various forms of strengthening. We use more of body weights because they are geriatric individuals. So we have to take care of their balance issues also. So we cannot give them a 5 kg dumbbell and start strengthening that way.
So, I don't see any specific
Questions?
question.
Okay.
I believe you've answered all the questions through your presentation. The
Okay.
meeting will terminate in the next 3 minutes. So,
Right.
any last message from your end, ma'am?
I am very, very grateful to you, Dr. Samir sir, because this is something I always wanted for Nagpur, and you have given me that platform. It is not just getting patients, it is about telling the students what we actually want to do, what you are doing. You people have, progressed to so much advanced techniques in the breath conference, which I have seen. So, physiotherapy should be an inseparable part of a pulmonologist. So, I just wish you hire more physios at your center, and I will encourage all my students to pursue cardiopulmonary physiotherapy, and let's take Nagpur to the next level. Lajvanti is always an inspiration for me as far as an academician is concerned, so she's
Thank
always
you.
there to encourage the
You are my
students.
inspiration. Your inspiration.
That way,
It
Ma'am,
was
so
really
we
very
can do it
wonderful.
together. That is what I feel. We can do it together. Yeah.
Yeah.
And
there's one question which is, ma'am, when to
Yes.
use Coach 1 and Coach 2 Spyro?
coach one.
And Coach 2 Spyro. That's a question that I can read.
Flow indicated spirometers are rampantly available. You can use it, but I told you the do's and don'ts. But I prefer using the volume. That is not the coach. The volume indicated spirometers. Those are more scientific and they cause less of, accessory muscle usage. So
Okay.
that way
Okay, my worry is the meeting might
will
terminate
get
by
over.
itself. So
Yes,
we have a WhatsApp group wherein you can
post your
post
questions.
your questions, and
Right.
the
And
group
we
will
will keep you
continue.
updated
Yeah.
with the next upcoming webinar. So thank you once again.
Also a physical meeting or a workshop also.
Yes, sir. Definitely.
Yeah.
Thank you so much.
Thank you, ma'am.
Okay.
Thank you, ma'am.
Thank you, ma'am. Bye bye.
Okay. Bye. Bye.
Bye.